Good morning. My name is Teresa Lee, and I apologize in advance. I have a cold right now, so my voice is not great. But today I'm presenting my adult GI soap. The patient's name is CW. She's a 24-year-old female, accompanied by her mother, and they are both reliable historians. Her chief complaint is abdominal pain and noticed possible blood in the stool about a week ago. So, history of presenting illness. The patient does have a history of cerebral palsy, mild case, AVP shunts, MTHFR gene mutation, and folate deficiency anemia. She's currently taking Xarelto for a history of DVT, and she presents today for a follow-up after being referred to the ER 1 week ago. The patient initially presented with lower abdominal pain and and blood in her stool. So CT of the abdomen revealed that there was a small perforation in the sigmoid colon, consistent with diverticulitis. After some discussion with a GI surgeon, they decided not to repair the perforation. So she was treated more conservatively with IV antibiotics, and then she was monitored in the hospital for 48 hours before being discharged on oral antibiotics. Today, she reports that her abdominal pain has significantly improved, but it's still mild and intermittent. And she denies any new bleeding, worsening symptoms, but she's concerned about her increased risk of complications because they never told her to stop her Xarelto. And then she's worried about her shunts as well. So briefly, her medical history, like I said, mild case of cerebral palsy. She's very high functioning. Diverticulosis, she was diagnosed with that 2 years ago. She had a VP shunt placed at the age of 2 for hydrocephalus. She does have a history of DVT 3 years ago, and she's on Xarelto for the prevention. She's got that MTHFR gene mutation as well as folate deficiency anemia. And then there's no other history of chronic GI conditions. So surgical history, again, was that VP shunt placement. Her current medications are ciprofloxacin 750 milligrams twice a day plus metronidazole 500 milligrams 4 times a day for 10 days, and that was given upon discharge from the hospital, so about 5 days ago. She's also on the rivaroxaban 20 milligrams daily for the DVT history. And then she's on a folic acid 1 milligram daily. And then no drug, food, or environmental allergies that she reported. Family history, no known family history of colorectal cancer or other GI conditions, so unremarkable there. And then social history is pretty unremarkable, or is pretty normal. She, like I said, is high functioning. She's living at home with her mother. But dietary, she does follow a regular diet. As of right now, she has been taking it easy with a gentle diet, and then just increasing to a regular diet as tolerated. Review of systems, everything is pretty unremarkable. She denies any, fever, chills, unintentional weight loss, no chest pain, shortness of breath, no new headaches or noticing signs of GI bleed. So she only reports mild intermittent abdominal pain and no new bleeding or vomiting. Her vital signs are stable, no concerns there. And then her physical exam was pretty unremarkable. Only thing was her abdomen was soft. It was non-distended, but there were no signs of pallor, bruising, or petechiae. There was only mild tenderness to palpation in the left lower quadrant, but no guarding or rebound tenderness. And the bowel sounds were mildly hypoactive throughout all quadrants. But she did report that she hasn't been eating very much. Again, she's just been slowly introducing things into her diet, but she was pretty clear liquid diet at the beginning. Okay, so recent diagnostics that were done was that CT abdomen pelvis done in the ER that revealed a very small perforation in the sigmoid colon. There were no large abscesses noted or free air noted. They also did a CT of her shunts, and that revealed no abnormal findings. And then her blood cell count, so her upon discharge, her white blood cell count had improved, her hemoglobin had improved, and then her platelets were stable and folate had improved also. And they all improved back into normal range. So for differential diagnoses, it was diverticulitis of the large intestine with perforation, and that was also the main diagnosis. The others were acute GI bleed secondary to the diverticulitis. So at this point, I was concerned that she was still bleeding. And then the last diagnosis or differential was colorectal cancer, just with any type of rectal bleeding. That should be part of the differential. So the main diagnosis, I chose this diagnosis because there was already some imaging done in the ER, and it was already confirmed that she had a mild perforation due to the diverticulitis, but again, there were no large abscesses, free air, or peritonitis. So they treated conservatively. And today, or at the time of the visit, because she still had some mild intermittent pain, I was concerned about still an acute GI bleed, but this was ruled out because she did not have any signs of active bleeding, so no blood in her stool, and like she states that her symptoms were improving quite a bit. As far as colorectal cancer, this cannot be ruled out yet. Or later in the treatment plan, we're going to discuss her colonoscopy in order to rule this out. So diagnostic plan today, or at the time of the visit, was repeating her labs, so getting a CBC, CMP, and then also a PT-INR. I wanted to monitor for any new signs of infection, obstruction, or worsening of the perforation. I wanted to consider, or I'm going to consider repeating her imaging if the patient develops a fever, increasing abdominal pain, or any signs of systemic infection. And then also monitoring for signs of bleeding due to her anticoagulation therapy. So treatment plan was to continue the oral antibiotics for a total of 10 days. So she still had about 10 days left, or 5 days left. I did start her on Fluorostor, which is a probiotic supplementation, 2 tablets by mouth twice a day for gut health. And then also to continue her rivaroxaban, 20 milligrams daily. But there was a stat referral made to the hematologist for management. And she had been seeing a hematologist previously. And then as far as education and further treatment, it was to advance the diet and increase fiber as tolerated, avoiding NSAIDs to reduce risk of further GI irritation. And then I also advised her to just rest and take it easy until she's fully recovered. We talked about symptoms worsening, or if new symptoms develop, such as fever or worsening abdominal pain, she needs to go to the ER right away. And then we did talk about some lifestyle changes as far as preventing any further or any future acute exacerbations of the diverticulitis. For follow-up, I did want to see her back in 1 week for a re-eval and then assessment of her recovery. And then if symptoms persist or worsen, I'll probably get a repeat CT abdomen at that time. And then we also discussed a colonoscopy following an episode of complicated diverticulitis, but it should be postponed for 6 to 8 weeks or until symptoms fully resolve, whichever period is longer, according to the AGA guidelines. And then I did do a referral to GI as well as hematology for management. So we talked about the management of the diverticulitis. I was following the AGA clinical practice guidelines, as well as the choice of antibiotics was also based on that guideline. And then continuing the anticoagulation therapy during the acute phase is also supported by clinical guidelines to reduce the risk of thromboembolic events. So, just weighing the risks and benefits, continuing the anticoagulation therapy had more benefit than risk to it. So holistic approach in caring science. I use curative factor number 4, which is develop a helping, trusting, and human caring relationship. I did not let her developmental disability stop me from educating her in the best way possible. I listened to her concerns about the shunts and doing a colonoscopy later, and she was actually really appreciative that I did not just assume that because she had cerebral palsy that she was not able to comprehend like medical terms and things like that. I did check in with her and ask if she did understand, and she said that like she was really appreciative of that. And as far as collaborative care, her mom was there with her, and so I was talking to the both of them and getting their input on the treatment plan as far as referrals and how they felt about doing a repeat CT later if symptoms did not improve. So again, they were really appreciative of the communication and just me not asking or assuming that they didn't understand things. And that is it. If you have any questions, please let me know.